And welcome everyone. We have an hour together this morning, which I'm sure will go by faster than we think, and we want to honor everyone's time, so we'll go ahead and get started here. Thank you all so much for joining us this Friday morning for a discussion on centering parenting. I'm Brittany Johnson, a Senior Program Manager at the New Jersey chapter of the American Academy of Pediatrics, and I'll be moderating our webinar today. And before we get started, I'd like to just thank the Burke Foundation and the Centering Healthcare Institute for their partnership and collaboration on this webinar. Our goal for this morning is to provide an overview of the centering parenting model, what it entails, and the value that it brings families, communities, and practices. In a nutshell, this two-generation intervention developed by the Centering Healthcare Institute is a model for pediatric group care that offers family-centered care to parents, caregivers, and children who meet with their healthcare team for 9 well-child visits over the first 2 years. And you'll hear much more about the model from our speakers. In addition, towards the end of our time together, we'll share information on an upcoming opportunity for interested practices to join the centering parenting movement with support from the Burke Foundation. Now, before I introduce our speakers for today, I also want to mention that all lines will be muted throughout the presentation to minimize any disruptions. However, we do invite and encourage questions, and at the conclusion of our presentation, we will have time for Q&A. So if you have questions for any of our speakers, please submit them through the Q&A box on the webinar control panel, and we'll invite you to unmute and ask those questions aloud during the Q&A period. One of the questions that we're always asked is, how can I access this webinar following the session? So I'll just quickly share that we are recording this webinar and we'll make it available on the NJAAP website, and we'll also share it with you via email on Monday. So if you want to take a look back at the presentation, or if you'd like to share this information with a colleague, you will be able to do so. So with all of that being said, we're joined by 5 fantastic speakers this morning who are so excited to share more with you on centering parenting. First, we'll be joined by Dr. David Willis, a senior fellow at the Center for the Study of Social Policy, who will help to set the stage and help us kind of frame how centering parenting fits into the larger context of early relational health. Then we'll hear from Deanna Velasquez, our New Jersey Centering Program Manager, who will provide a breakdown of the components of centering and explain to us how it can be integrated into practice. Followed by Usha Ramachandran, Associate Professor of Pediatrics at Rutgers Robert Wood Johnson Medical School, who will help us understand the case for centering by highlighting some key outcomes. Then Dr. Rachel Evans, Chief Medical Officer at the Henry J. Austin Health Center, will share insight with us on her federally qualified health center's journey and experience implementing centering. And last but not least, Renee Nogales, Program Officer at the Burke Foundation, will have us look ahead and explore how we can expand centering here in New Jersey. So without further delay, it is my pleasure to turn things over to Dr. Willis.
Thanks so much, Brittany. Good morning, everybody. It's a thrill for me to be here. I'm David Willis. I'm a developmental behavioral pediatrician, senior fellow at the Center for the Study of Social Policy, and I'm working nationally with states and communities to advance early relational health for child health transformation and for community change and for the improvement of the lives of children and families. It's a delight to be with you this morning and for this kickoff, and to highlight a few key points about what is important that you're going to be hearing soon about the centering parenting model and the opportunities that are coming forth for you in New Jersey. I've been a champion of early relational health for most of my career, knowing the importance of focusing, partnering with families about strengthening their earliest experiences with their young children. The science is clear from the neuroscience, from the neurodevelopmental science, from the field of infant mental health, from child development and the social sciences, that the criticalness of focusing on those early relationships is what builds health, early learning, social emotional well-being, and future well-being for a lifetime. Those foundational relationships really matter. I've also been a longtime champion of child health practice transformation, new ways in which our opportunities in pediatrics, where we see basically all families who seek the well-being of their children, as do we, the opportunities of strengthening the way our practices operate in terms of focusing ever more on those relational experiences. We call that now early relational health, and the importance of focusing and partnering with families around those foundational relationships. So today, you're going to have an opportunity to hear about one of those advanced level innovative models that are in the center of moving forth early relational health opportunities. It satisfies so many of the needs that we have in pediatrics to partner in new ways with families on one hand, providing a practice opportunity that gives both more time and more supports to families and satisfies us as pediatricians to knowing we're really achieving the hope of improving the well-being with families and efforts. The Centering Parenting model is evidence-based. It's a group-based well child care model built on bright futures, innovative in the way that it operates in providing a group opportunity for families to be together and to learn from one another, as well as for we as child health providers providing the best knowledge we have, but still preserving that individual relationship during the visit with families. The magic of the centering model is how deeply it focuses on their relational experiences at every level. Imagine a group coming together of families of young children, infants and young children, all of the same age, sharing with each other, watching the interactions from one another, you as providers being able to participate in their discussions and add our knowledge about the issues that matter most to families, not only sleep issues, feeding, importance of vaccines, nutrition and play, but importance of focusing on relationships. The other magic of this model is that it's all relationally centric. The relationship between young families and their young children, the relationships between parents with each other, and those social connections and social relationships that we're learning last long years, if not for a lifetime, as well as the importance of the relationship between the families and the care team, the child health care team. All of that is a nurturing experience. All of that levels the playing ground of the relationships between child health providers and families. The family experiences are striking. They will tell us, and you'll hear today, about how meaningful this is to have more time, how meaningful it is to have relationships that build, countering isolation, and feeling much more equal in the relationships with the care team. It also brings incredible satisfaction to physicians who've longed for having more time with families, who wish to be able to share more of our knowledge base with families, and to have more of a more intimate relationships with families over time. We also know that in this tough time of COVID, there are many challenges, and yet I'm excited to know that the centering parenting model actually has been able to continue successfully during this COVID period and is ever more important about countering the isolation and the fears that we all have in this moment. The most important other element that we all worry about is this is a billable primary care health visit. There's not now the barrier to group health care that we've had previously. That's really significant. So in conclusion, and what you're going to be able to hear today, this is an incredible opportunity and as an exemplar to promote the transformational process of early relational health and child health care. And what you'll also hear is how your chapter and through the generosity and the vision of the Burke Foundation, see that Jersey has an opportunity to really expand this model ever more importantly. So I'm thrilled to be a part of this journey with you. And so let me now turn it to Ms. Deanna Velasquez, who's a program manager with the Centering Healthcare, to kick us off further to learn about this amazing model. Thanks.
Thank you so much, Dr. Willis, and it is a pleasure to be here today. Today I'm going to talk about the Centering Parenting model and what is going on with New Jersey and what it looks like overall. So next slide, please. And one more after that. So our mission here at the Centering Healthcare Institute is to improve health, transform care, and disrupt inequitable systems through the Centering Group model. Next slide, please. The Centering Healthcare Institute is a nonprofit organization that works closely with healthcare providers from all sectors to change healthcare. So we have over 2 decades of experience as the go-to resource for group care, and we've developed and sustained the centering model in more than 560 practice sites. We've reached out to over 70,000 families, and we are in some of the largest health systems in the world. Next slide, please. So exactly what is centering? Centering is an evidence-based model of care where patients are seen in groups rather than one at a time. The centering model combines the health assessment, interactive learning, and community building to support positive health behaviors and drive better health outcomes. Next slide, please. The centering model has 9 essential elements which ensure model fidelity and sustainability. The essential elements define the centering model They're the framework of care and the foundation for our successful outcomes. Sites go through an accreditation process to ensure that they are following model fidelity and the 9 essential elements are woven throughout their group care within each session. Next slide. So the Centering Healthcare Institute has 3 group care models. Centering Pregnancy is our flagship model. It has cohorts of 8 to 12 women of similar gestational age that travel through pregnancy together, and it follows the ACOG and ACNM practice guidelines. Centering Parenting is our pediatric care model, and we'll really dive into that a little bit more. And Centering Healthcare is the framework that sites can use to deliver centering group care across multiple health conditions and patient populations. Next slide, please. So let's talk about Centering Parenting. It is group well child care. Our pediatric care model is structured around AAP's Bright Futures practice guidelines, and it starts from 0 to 24 months. So groups of 6 to 8 same-age babies and their parents or guardians will come together and meet in a group care from 90 minutes to 120 minutes. There's about 9 well child visits, and what's great is this is flexible to accommodate your community. So if you need to have more, you can absolutely schedule more. The visit schedule starts around 1 month and ends at 24 months. What's great is that we currently offer in-person as well as virtual group formats. The University of Maryland, Baltimore Washington Medical Center has successfully adapted the Zoom platform to offer centering pregnancy and centering parenting groups virtually after a brief hiatus following closures due to the current pandemic. And it continues to serve its centering parenting patients through the crisis, and it reduces the need for in-office visits and care when applicable. So the providers at UMBWMC are using the Zoom platform to facilitate their centering groups online while providing education, peer support, especially in this time of isolation, which is so important. And there's brief office visits are still available if vaccines are needed, and patients who receive medical examinations in person as well. And currently, UMBWMC serves 22 centering parenting groups and 6 centering pregnancy groups. So their virtual platform is really helping the community come together in this time of isolation. Next slide, please. So centering parenting offers continuity of care from centering pregnancy as a standalone model of group care, beginning with the arrival baby through 24 months. And it can be implemented as a pediatric model or within family medicine where both parent and baby are cared for. The materials are organized in a way that adapts to additional visits, and each patient receives a centering parenting notebook. So they're able to track their baby's health and they're really empowered to be engaged. The parents or guardians will do self-assessments with their babies, and there's a medical screening with each provider. We have a quote here from Brittany Hipkins, who is a third-year resident, and she said, "I think group model of care is something that is going to be the way of the future." And she's from MAHEC Family Medical Residency Program in Asheville, North Carolina. She trained as a medical student with the centering model, and Brittany realized that delivering care in a group was very different from traditional visits. The rushed appointments every 20 minutes and individual patient slots in clinic with documentation to fill, versus having an opportunity to have more time to observe the patient-child behaviors and interactions as a facilitator in the centering parenting groups. It was a far richer experience for her as a provider, and she realized that this innovative way of seeing patients in clinic was not disruptive at all, but facilitated everybody's goals around improving healthcare and the delivery experience. It increased provider and patient face-to-face time, and there was a better patient experience and greater provider satisfaction. To quote Brittany Hipkins, "I hope more residents and professionals are able to get training in this model and get more experience in their training years, because I can still see the same number of patients in the same amount of time, but the quality of those interactions is far greater." There's a 2-hour billable visit. Parents have a one-on-one assessment with the provider, and then the group comes together for group discussions. Each parent is actively involved in their child's assessment at every visit, tracking their growth, development, immunizations, oral health. There's individual well-child health assessments, immunizations, and developmental screenings, which follow the Bright Futures nationally recognized guidelines. And there is an emphasis in the curriculum on self-care, wellness, and women's health is woven throughout. Next slide, please. So think about if you're a patient. Your appointments are scheduled in advance. You're able to plan with your provider what your schedule will be for the next 2 years. You're able to make arrangements with childcare if needed. You avoid a long checkout line, and you have more time with your healthcare team, time for questions, sharing, and learning. You're learning about the importance of self-care and wellness. You're feeling empowered, respected, and confident, and you're a collaborative partner with your own healthcare team. Next slide. Think about the benefits of the provider. You're able to spend additional time with your patient. You're not rushed in the typical 15-minute appointment. You're not being stressed because your schedule's running behind. You know that your patients not only have the information they need, but they understand the information that you're providing to them. You have time to observe patient interactions with their babies and their behaviors instead of just relying on quick screenings. And you're working with really activated and collaborative patients. You have a deeper and more meaningful relationship with your patients, and work is fun and energizing now. Next slide, please. If you're an administrator, there's added value to your practice. So you have an extraordinary patient experience, better health outcomes, happier providers, predictable clinic schedules, additional available exam rooms while centering is in progress. And it's a cost-neutral way to provide care that offers so much more, and an innovative offering to market to new patients. Next slide, please. So we are going to show you a great video called Patient Voices. Well, you'll get to see patients in centering groups and hear their experience from not only patients, but providers as well.
Centering gives you the understanding that you are not alone.
Pues de mis otros hijos nomás venía con el doctor y ya me regresaba a la casa, y aquí no, como que me relajo estando con las compañeras y pues me siento más a gusto así venir a las citas, como que vengo más gustosa, como más positiva.
If ever you need to talk to somebody, or if someone needs to talk to you, some people just need the extra hand or somebody just to lean on and talk to. It's teaching me new things that I didn't know.
It's giving us more of a bonding experience around our daughter's health care and a proactive approach to her health care. Because we're talking in this group ahead of time about what we're going to be experiencing as our babies grow. So I really feel like it's helped us be more proactive parents.
For me, it was very important that they ask about my well-being, let's say, if I'm healthy, if I'm feeling down, or if I need like any type of assistance.
Lo que me hizo venir a los grupos de Centering es que me recomendaban mucho porque es muy, como puedes socializar más con las personas.
It's just kind of all in one. It's not just, you rush into the doctor and you've got maybe 5 minutes with the doctor, and of course you forget everything you wanted to ask the doctor in those few minutes and think of them on your way out.
It's nice to know other people are going through the same thing you are.
Con mi bebé, con mi embarazo, y aún sigo aquí, y se lo recomiendo, que es una familia. Es una familia. I just love how the centering involves the dads as well, how they give them the same resources that they give us, teaching them parenthood and how to be a dad, and giving them the understanding and involvement. We talk about so much, even family dynamics, communication, also the personal relationships that we build here makes you more comfortable, makes you more confident. When you're confident, you're at least able to have enough courage in yourself to be like, if I don't know, I can at least figure it out.
I would like a parent to come to CenteringParenting because you
get a lot of experience, different experience from others. You get to spend more time with the doctor. You get more time to interact with them. They get to know more about your child.
Espero, si Dios me lo permite, espero que después que tenga mi bebé, yo pueda regresar a CenteringParenting para seguir aprendiendo más sobre ser una buena madre.
Aren't those babies just adorable? So as we move towards expanding centering parenting in the state of New Jersey, there's opportunities for your communities to connect further. There's also opportunities for you to connect with us via Facebook, LinkedIn, Twitter, or centeringconnects.org. And it is my pleasure to introduce Dr. Ramachandran, who will be our next speaker.
Thank you, Deanna. I am an associate professor of pediatrics at Robert Wood Johnson Medical School. I provide primary care to children at a federally qualified health center, and I teach medical students and residents. I'm also the medical director of Reach Out and Read, New Jersey. Next slide, please. So in their policy statement on the medical home, the American Academy of Pediatrics states that the medical care of children should be accessible, continuous, comprehensive, family-centered, coordinated, compassionate, and culturally effective. Next slide, please. However, many families, especially the most vulnerable, report that some of their needs are not met during traditional well-child visits. Physicians as well report that the traditional well-child visit does not really give them sufficient time to provide all the anticipatory guidance and the advice that they think is very important to provide at preventative services. And these have been, these findings have been reported from studies that have looked at this. But centering parenting provides a structurally and philosophically different model that may help address these unmet needs. Next slide, please. So what are the differences between a centering parenting visit and a traditional well-child visit? The biggest difference, of course, is that it's a group visit versus an individual visit. And the length of the visit, a family gets to spend 1.5 to 2 hours with the healthcare team in a centering visit, as opposed to an average of about 20 minutes in a individual well-child visit. And of course, this provides doctors and other members of the healthcare team with an opportunity to really build those, strong connections with their families, spend more time with them, discuss topics that are important to families, and more than anything else, observe how families interact with their children. And families get, a chance to see how other families interact with their kids and learn from that. And providers are able to model those healthy parent-child interactions and great ways of engaging with their kids, which, as Dr. Willis mentioned, is so important to the development of children and to their future life course trajectory. In terms of philosophical differences, the major difference is that centering parenting stresses a facilitative approach rather than a didactic approach. So healthcare providers become facilitators of discussions where families can learn as much from other families as they learn from healthcare providers. It involves active participation of parents, as Deanna mentioned as well. Parents help with measurements of height and weights and head circumferences and help plot their children's development. And it really fosters that active engagement in their child's health. It has a bi-generational approach, focuses on the parent-child dyad rather than just the child, and really looks at addressing measures of parental well-being, things like screening for maternal depression, stress reduction in families, and contraception, family planning, and lots of other things that have to do with the parent's health and the family's health. And this, again, is so important. If parents are not in the best of health, either physical health or mental health, they may not be in a position to develop those strong, safe, stable, nurturing relationships with their children, which again, as Dr. Willis mentioned, are so critical in a child's development and life course. It encourages peer-to-peer learning and support, which is really one of the biggest strengths of this model. And lastly, centering is a model that really incorporates aspects of trauma-informed care. So things like building trust with families, collaborative approach with families, peer support, family empowerment, responsiveness to families, all of that is addressed really well through the centering parenting model. We're able to address adverse childhood experiences, toxic stress, screen for social determinants of health, and refer families to resources as needed. Next slide, please. So to look at some of the evidence in the literature to support centering parenting, what do parents think about centering? Parents perceive more social and wellness benefits from centering parenting and a greater satisfaction with the delivery of care from the centering model as opposed to regular well-child visits. And one study actually reported that almost 100% of parents reported having enough time with their provider during centering visits and reported that all their needs were met during the visit. Next slide, please. One question that frequently comes up when we mention group visits, even though group visits have actually been around since the 1970s, they've been studied since the 1970s and have been shown to have lots of really great benefits. A question that often comes up is, are families going to feel comfortable discussing their child's health or the family's health in a group setting? And there's evidence from literature, studies show that families do in fact feel comfortable at group visits. In fact, families that had the option of, who had been exposed to centering parenting overwhelmingly reported wanting to continue with centering parenting for their well-child visits rather than going back to the regular well-child visit format. And one thing, you know, the big strength of parenting, the one thing that's mentioned over and over again in studies is that parents talk about the importance and the benefits of learning from and building relationships with each other. So building this community of support, giving families and children a sense of belonging to the community. It's just, you know, the centering parenting approach kind of builds all of those relationships. And that sense of belonging to a community has also been shown to be a big factor in promoting resilience in families as well. Next slide, please. So what do providers think about centering? So studies have shown that providers report high levels of self-efficacy in implementing centering parenting models. They reported that they're better able to address concerns of parents in the group setting rather than in traditional well-child care settings. And most of all, providers and staff reported higher levels of satisfaction with the centering parenting model compared to individual well-child visits. And I think, you know, in the context of the high levels of provider burnout that we're seeing today, this can be a really powerful tool to help mitigate that burnout. Just having that opportunity, that 1.5 to 2 hours to really interact with families, build those strong relationships, get the sense that you're making a real difference in their lives, I think can be a really powerful tool to sort of help us all avoid burnout. Next slide, please. In terms of outcomes for children, centering has been shown to be associated with higher attendance at well-child visits and has been associated with more timely immunizations. A randomized control trial is currently in progress at Boston Medical Center, and that's looking at language outcomes at 24 months, healthcare utilization, parental stress, caregiver behaviors and attitudes, and multiple other outcome measures as well. So I just want to conclude by saying that the evidence clearly points to the fact that centering parenting provides an opportunity for providers to really strengthen parent-child relationships. And there's evidence that it supports relationships of families with communities. And there's evidence that it supports provider and parent or provider-family relationships as well. With that, I'd like to turn over the talk to Dr. Rachel Evans, the Chief Medical Officer of Henry J. Austin Medical Center.
Hello, everybody. Good morning. Thank you so much for inviting me to be here. I'm very happy to be here. If you happen to hear some background noise, somebody please let me know. It turns out it's music class in 5th grade, and that involves recorders all of a sudden right now. So please let me know if you hear anything sort of seeping through. So I'm Rachel Evans. I'm the Chief Medical Officer at Henry J. Austin Health Center. And just a little bit about my background, I'm a family medicine physician. I did my training at the University of New Mexico, and then I practiced at a federally qualified health center there for several years. And this was years ago, but at the time I was in a very rural community, and I got to deliver babies, and I got to really take care of the whole patient from birth to death and everywhere in between. And while I was there, I had the extraordinary good fortune of participating in a centering prenatal model. And this was very early on. It was a project that had been funded in conjunction with the hospital. So it was myself and a nurse who was also a breastfeeding consultant. And we were able to do centering groups with a group of women who were the wives of dairy farm workers in rural New Mexico. And it was really amazing. These were women who weren't even sure they had access to healthcare, and being able to do these group visits in their little trailer homes on this large dairy farm was really remarkable. And everything you've just heard about the centering model, I got to see it come true. In particular, that empowerment, that feeling of community, that sense of seeing these women who were mostly undocumented and extraordinarily vulnerable with very few resources, really be able to come to support each other and create a community that felt safe for them and their families. So I have been in New Jersey since 2012, working at Henry J. Austin Health Center. We are also a federally qualified health center. And when we first started having conversations about centering, I was so excited because I'd had that experience with prenatal centering and was very enthusiastic about maybe being able to bring centering to parenting and pediatric services at Henry J. Austin. Next slide. So one of the things that, of course, motivated us to try to partner with funders to create a centering model, and we've been really fortunate to be able to work with the Burke Foundation and the state of New Jersey, is that there is a crisis in maternal and infant health in New Jersey. And when I say a crisis, what I mean is that outcomes for Black and Latinx moms and babies are significantly worse in New Jersey and have been so for over a decade. And so this is something that received a lot of attention in the last year, where at the state level, I think there is some really valuable work to say, let's try to address this. We have many valuable local programs. We have many health centers and healthcare services that are doing their very best to provide services for these moms and babies, but the needle is not moving on those pregnancy-related complications and those infant and maternal mortality rates. And so there is a commitment made to try to move towards centering as an evidence-based model that has been shown to improve those outcomes. And we were really excited to be part of that. And then just everything that you just heard about how the model encourages this empowerment and increases these outcomes, including immunization and breastfeeding rates. Next slide. So we started off on this journey really trying to think about how can we transform our preventive pediatric services at Henry J. Austin. We created a centering space. We got training for our staff. We were very enthusiastic and very excited. And then we had just barely gotten started and the pandemic happened. And so that's one of the things that I think is really important to highlight about our experience. I saw some questions in the chat about parenting centering in particular that I think are great questions, and we'll get to them. But I just want to be clear that our experience was we started centering parenting, and then all of a sudden we were having a pandemic. And of course, one of our first conversations was, can we still have our centering groups? And at the end of March, when numbers were just surging as they are again in New Jersey, we really felt like it was not responsible to bring dyads, to bring parents and babies into a close room together. So we decided to try to switch over to virtual sessions. And that was, the Centering Institute was extraordinarily supportive, but it was also interesting because here we are just barely learning how to do this model. And all of a sudden we're saying, okay, now we're going to try to do it in this other way. And there's no one else is doing it, or other people are trying to do it. But as Deanna mentioned, there are other organizations that are doing this now, but we were all just sort of figuring it out as we went. So we did manage to switch over to centering group sessions. We do use 2 platforms for that. And there was some specific questions about the billing and coding piece and the documentation piece. And I'll just say briefly, for parenting, the group visit codes are not yet reimbursable. They are for prenatal care. So what we've been doing is making sure that each patient has that one-on-one time with the provider to meet the criteria for billing for individual visits. And the way that looks is you have the group visit and you have it in the Zoom platform. And then we will pull patients out into our telemed platform for that individual one-on-one. And it's just the same as if you're in a group setting, you would pull that dyad into another space just to do that one-on-one time that's required for that billing criteria. The other thing that was a real learning process for us is that we provide integrated behavioral health services with all of our primary care visits. So as you've heard, the centering model really is built around that wellness of the family unit and thinking about those behavioral and developmental concerns. And because we have a lot of that screening and support built in our integrated primary care model, one of the things we had to do was figure out how to continue providing that in our centering model. And what we found is that it's been very helpful to have one of our behavioral health counselors be the co-facilitator. And so then similarly, when concerns come up either in the group discussion or with the screening tool, they can pull that person aside for that individual one-on-one or schedule them later as need be. So that again has been sort of part of that learning process. Right now, at this point in the pandemic, we have 10 cohorts, so that's a total of 36 centering babies. And we have groups that are in both English and Spanish, and that's how we've decided to base our group, so that some will be in Spanish and some will be in English, and we have them once a week. So our provider, our clinical team that does the centering, that's what they do with their Wednesday mornings. Next slide. So in terms of challenges, of course, there have been more than usual. One of the things I myself really appreciated about the centering training is that I think it emphasizes a lot how to encourage patients to want to participate in centering, but also how to get that buy-in from your organization. Doing anything different in healthcare is hard. It's sort of a deeply conservative structure for the most part. And so a lot of that training is around how do you train everybody from registration to your unit receptionist to your nurses that centering is the model we're doing so people feel comfortable with it. I think for us, again, it was a little bit unique. We were in the process of trying to recruit. And then when the pandemic happened, we were suddenly talking about some very different things. So one of the advantages of centering is patients don't have to wait for their appointments. They don't have to do all that check-in and registration process first. It's much more streamlined. Patients can just come in and be seen. What we found at the start of the pandemic is we switched 95% of our services over to telemedicine, and we really had to figure out that remote registration piece. So that's actually true now for all the visits at Henry J. Austin that are telemedicine related, and actually on site now as well. We do the registration remotely and it isn't impeding the time of the visit. So that was an enormous learning process and just structural reorganization process. The other thing I think that really helped us was when you talk about change and how do you make this part of how you provide care, we were also doing the same thing with telemedicine at the same time. And we had been trying to do some telemedicine for a while without a lot of engagement. And when the pandemic happened, we just pushed our organization off the cliff and said, it's going to happen. It's happening. It happened. And everybody kind of had to figure out how to do it. And so in a sense, everybody's mind was just sort of blown wide open, and centering became something that our clinical teams got to hang on to as, hey, this actually feels kind of normal and comfortable. So I think that really helped us. And same thing for the patients. Those who had already been engaged in centering, all of a sudden they were in a completely different landscape. They were isolated. They were stuck at home with their small children. Being able to have that community and access that group support became even more important. Another challenge, of course, was attendance due to these technology challenges. So for us, it was a learning process. How do you troubleshoot a Zoom session? How do you troubleshoot a telemedicine session? How do you make sure that everybody participating has the access to technology that they need? How do you do it on a phone versus on a tablet? I think everybody here probably has had a lot of these experiences by now where your clinical team suddenly has to sort of become IT support from your patients if you're trying to do this. And that's not something that we're typically used to, but everybody had to learn along the way. We, of course, we're a federally qualified health center. Our patients are often below the federal poverty level. There's often a concern about access to technology, but we have found that with some support, all of our centering moms and parents were able to participate. We just have to make sure we have that engagement and connection. Next slide. A couple other things we learned. So with the centering model, there was some, I saw a question in the chat about documentation. So you're documenting on each encounter individually, but one of the things that really helps, and this speaks to that provider and team engagement as well, is you start out with a little sort of huddle at the morning. You talk about what's going to happen. You make sure you know what's going on with all your patients. We've learned that if you're having your Zoom session start at 10 o'clock, you want to do your login time at 9:45 so you can address all those tech issues. And then at the end, when you finish, there's a debrief with the clinical team just to talk about how it went and to get that documentation done. The thing that our clinical team reports that feels sort of magical is they wind up getting to see more or less the same numbers of patients in the morning, but the flow is so very different, and they get to spend that time where they truly feel like they're spending more time with each family and each patient, and then they're able to do that debrief as a team at the end. Next slide. A couple other tools. We found that social media really helped with engagement. We did a Facebook Live event. We've been marketing the program on our social media platforms. Another piece that we heard from the Centering Institute that turned out to be true is not to worry too much about how large the cohorts are. So we kept asking, well, how many babies, how many do you need to start? And they said, just start. And it's true. You just kind of have to start, and then more babies, more kids that age will join the cohort. And it's for the families. Being in that small of a group is enormously rewarding. And then when more people join, it just sort of expands that connection. So I would really encourage people to say, if you're considering starting a centering program, just go ahead and do it. And then it almost sells itself. It's very rewarding. Tools, there's several different tools that have been important. We have calendars to keep track of things. You want to know who are all the families that are engaged in the centering and make sure that they've got that connection, particularly in the remote environment. And this is true about all our telemedicine services. Having somebody in our team, it's usually the medical assistant or the unit receptionist, who is personally engaged with all the families, reaches out to them ahead of time, makes sure they're going to come, and checks in with them in between. Particularly if they're Spanish speaking, that needs to be a Spanish speaking person. That has been really helpful for us, and I would strongly recommend it. Next slide. Oh, so that last one was lessons learned, but I think the thing I really want to emphasize is that we had already heard here about the benefits of centering, but for us, particularly during the pandemic, we have really seen how powerful it is to have this platform for engagement. And I think that sense of isolation, particularly that new moms or that single moms have, is even more amplified during the pandemic, and being able to do group visits is very powerful. The other piece that I love about centering is that it just takes that relationship between the provider and the patient and it turns it on their head. So Henry Johnston is a federally qualified health center, we are a patient-centered medical home. We try to do all the right things in terms of cultural humility and having services in your language of choice, et cetera, but we still have a lot of medical providers and clinical team members who want to educate, and that means they like to talk at their patients. And the point of a centering meeting is that it's the patients and their parents who are speaking, and so it really shifts the dynamic. And I could just see this profound change in my pediatric teams where they were learning from the patients. They were starting off saying, oh, we're going to teach the patients this, and then they came out of the session saying, wow, look what we heard, look what we learned from our patients. And it really does allow the families to drive what that conversation is about. Just to speak to a couple of the questions I saw in the chat, you are still doing all the elements of a well child visit. So everything recommended by Bright Futures, all the developmental screening, all those different pieces, you're doing them and you're documenting on them within the visit. But then what you're focusing on in terms of the education and anticipatory guidance really shifts, and that is highlighted by the centering activities. So as you go through the activities of the session, the group guides towards what is needed and what that conversation is going to be. I see a couple technical questions. We do have a Spanish-speaking provider for our Spanish-speaking groups, but we also have, a lot of our Spanish-speaking groups will have a Spanish-speaking medical provider, but our behavioral provider is English-speaking, so we have an interpreter, and that works well. I've even seen groups where we had patients, both English and Spanish-speaking, attending, and somebody to interpret as needed. It's slower that way, but the patience and engagement is really high. And so when people are committed to do that, it really works. I see a question about how do you regulate the group conversation over Zoom so that everyone is heard? And I think because they're smaller cohorts, so we're talking about 5 or 6 patients, it's really just that initial question of, we all had to learn to put our mutes on when we weren't talking and how to take our mutes off when we wanted to talk. But the chat feature is amazingly powerful as well. So once our families start figuring out how to use that, then they're speaking when they're speaking, but when they're not, they're able to join in with the chat as well. I know there's going to be more time for questions later. So sort of as a final piece, I just would like to say this past year for, I think, all of us has been different than we would have expected, very different in a lot of different ways. Trying something new like centering is a leap for a health center, but for us, it's been very rewarding, and even more so now that we don't know how much longer we're going to be in pandemic times, but it really has allowed us to connect with our families in the way that we would hope to. So it's definitely been a positive experience for us. That was all that I had to say. I know there'll be time for questions later, and I would like to pass it over to Renee Nogales, who is a project officer, a program officer at the Burke Foundation. Thank you so much.
Thank you, Dr. Evans. Centering is one of the maternal child health initiatives that I support at the foundation, and I am really thrilled to be here today with such an amazing group of champions for infants, toddlers, and their families. The Burke Foundation invests in the most promising and transformative programs and policies that foster the health, well-being, and resilience of children and families in New Jersey, particularly in under-resourced communities where our support can have the greatest impact. Our journey with centering began over 3 years ago when the foundation consulted with researchers and experts and service providers on the ground as part of a national field scan to help answer the question, what are the best-in-class program models out there to improve outcomes during the earliest years of life when brain development most influences lifelong well-being? And centering was by far one of the models that rose to the top. This led us in 2019 to join the New Jersey Department of Health, the Nicholson Foundation, the Taub Foundation, to pilot 5 centering sites as part of First Lady Tammy Murphy's Nurture New Jersey initiative. And as you've heard, during the pandemic, several sites have been using telehealth to continue serving families through individual and group engagement. And given how critical the first weeks and months are for new babies and the added risks for parents that can emerge from social isolation, a program like centering has become more important than ever since COVID-19 began. Overall, there are 15 centering pregnancy sites and 3 centering parenting sites in New Jersey, but that's not enough. The opportunity that centering offers to achieve the quadruple aim, better patient care, better outcomes, higher job satisfaction among providers, all at lower costs, has really galvanized the Burke Foundation to partner with Centering Healthcare Institute to support, scale, and sustain this innovative model at 50 new sites across New Jersey over the next 5 years. And I hope that our panelists have inspired you to act on this timely funding opportunity. And since we appreciate how the pandemic has stretched everyone's bandwidths, we want to make the application process as streamlined as possible. Next slide, please. The first step will be to complete a readiness assessment form from Centering Healthcare Institute, which takes about 30 minutes to complete, on topics such as patient volume, the number of clinical providers who will likely participate in centering, the proposed space for the groups, and the demographic mix of your patient population. And this information will give the CHI team insight into your practice's readiness to begin this journey, the goals you have for implementation, and the community that you're serving. Once you've completed this form, you'll have a follow-up call with the CHI team member to discuss your responses, as well as, to get any answers to any questions that you or your team have. CHI will then determine whether additional information is needed, and once readiness is established, you'll be invited to participate in the RFA process, which will entail answering a short set of supplemental application questions. The first RFA will be released in December, which will result in 5 awards for Centering Parenting. And a second RFA will be released in early 2021 to support 5 Centering Pregnancy sites. And the strongest submissions will be funded as part of this first cohort of 10 sites, and other promising applications will be considered for future rounds. And funding will cover training and technical assistance from Centering Healthcare Institute for the first 2 years, along with mini grants to support some startup operational costs. Next steps would include connecting with Deanna with any questions you may have, submitting a readiness assessment, and we will include a link to the landing page for this funding opportunity in the follow-up thank you note that you'll receive on Monday. And this is also where the RFA will be posted in December. So I want to thank everyone for joining us today. I really want to extend my deep appreciation to NJAP for hosting today's webinar and for each of today's speakers. As true believers in the centering model, the Burke Foundation is grateful for their support and partnership as we look to bring centering parenting and centering pregnancy to more families in New Jersey. Thank you, and I will turn it back to Brittany.
Wonderful. Thank you, Renee, and thank you to all of our presenters for sharing such wonderful information on the centering parenting model. So without delay, I'm looking at the time. I realize we only have a few questions. We only have a few more minutes. So we'll want to squeeze in as many questions as we can. Davina, Midge, and Jamie, I can see that in the chat and in Dr. Evans' reply that she responded to your questions already. But if you have any follow-ups, please be sure to share those with us. And next up, I see, Dr. Kroll, that you've shared several questions with our group. So I'm going to open up your mic and feel free to ask our panel whichever question you'd like.
Oh gosh, yeah, I'm just trying to wrap my head around when I would document all the documentation that I would need to do for each of the children, how you work that in. I think that's the main one. And then just how if at all, you've thought about, do the changes in the E&M coding now, how that's going to affect how centering pregnancy is funded. And then finally, just interested in what the upfront and ongoing costs are to participate. It seems like there must be some costs to the practice that wants to do it, even if they're not participating in the RFA or getting funding. Can you talk about that? Sorry.
Oh, Dr. Evans, I think you're on mute.
Sorry, I'll speak briefly to the documentation piece. We've gone about this a couple different ways. When we were in person, we actually considered having, because we had scribes at the time, having a scribe participate and just making that happen quietly in the corner with their laptop. But we switched over to the pandemic setting too quickly to really give that a try. What I do know from what we did in practice is that one of the nice things is the vital signs and other pieces like that are actually done by the parents themselves and then entered in by the medical assistant at the time of. And then the way we've scheduled it is we allow some time after the visits for that documentation to finish up. I think it's very individual to the providers. So even in the group setting, there are some providers who are able to do the majority of their documentation with templating, et cetera. And then there are others who just need that time afterward to do it. What we have found is there is upfront energy and cost, particularly if you're trying to create a space for it. But then once you're sort of running with the program, it requires about the same staffing for the same number of patients that you see in a half day. So it winds up being more or less revenue neutral in that sense. And then, of course, with all the gains for the providers in terms of burnout and for the patients in terms of outcome. But I can't speak to the billing with the new E&M codes. And I would add, we were lucky enough to have funding to support that piece. And that's a great question about private practice, because I can only speak to the health center funding and billing and coding pieces.
I'm unable to speak on the billing as well. That is not my wheelhouse, but there are private practices that are participating in centering parenting across the United States. The centering model is across the United States, even in Alaska and Hawaii. So we do see all different types of practices that offer centering parenting. And to talk a little bit about the documentation too, the Centering Healthcare Institute, when you're in a group setting, we advise if you could take some time before and after the session to do some charting. That works well. So that's another option when providers are doing documentation. There's also a provider facilitator and a staff facilitator in each group that's assisting with the 90-minute to 120-minute group.
Great, thank you, Deanna, and to Dr. Evans. Next up here, I see a question from Nancy Montville. So Nancy, I am unmuting your line.
Thank you. Can you hear me?
We can hear you, yep.
Okay, so my question is, we're a very large private practice, and we take we take 3 different Medicaid plans, but we also have private insurance patients. Would we be eligible to apply for the program?
That's a great question, Nancy. I would encourage you to connect with Deanna and have that conversation with her. I think that we are going to try to prioritize, FQHCs and community health centers and hospital-based clinics that do take, a sizable number of Medicaid patients, but we would definitely invite applicants from private practices that also serve those high need populations. So I would just encourage you to reach out to Deanna.
Okay, thank you very much.
Sure.
Great, thank you, Renee. And then I see another question here from Melissa. Melissa, I'm going to allow you to talk and you should be able to unmute yourself now.
I was just wondering usually what kind of licenses the people have who facilitate the groups.
So because it is a billable visit, there's always a provider facilitator, so a pediatrician or a family doctor. And then as a staff facilitator, that is really varied. So that could be a medical assistant, it could be a lactation consultant, it could be somebody in behavior health. It's really who would be best to support your community. And there's typically more than one facilitator team at each practice. So it really helps engage the patients. It's really an internal system change and not just a program you're implementing, and it gets everybody involved in centering parenting.
Okay, thank you.
Great, thank you, Deanna. And I'm just looking, I know that we're getting close on time here. We do have lots of other great questions about the centering model in other parts of the country, and so on and so forth. So we will be getting back to everyone with responses to those questions following the webinar. I do see a question here as well, just about getting a copy of the slides and a copy of those questions. So we'll certainly be sharing that with folks after the session as well.
Are you picking your stuff up?
Sorry, what was that?
Let me know when he's back from Jersey City.
Lori, if we could just go ahead and mute lines. So we'll just go ahead and wrap up here then. So on behalf of the New Jersey chapter of the American Academy of Pediatrics, the Centering Healthcare Institute, and the Burke Foundation, I'd love to extend another warm thank you to all of our presenters for sharing their time and expertise with us today, and all of our participants on the line for taking the time to attend this webinar. So as I mentioned, we'll be sharing the link to the recording of the webinar via email on Monday, along with some additional resources and the follow-up to the Q&A. Thank you so much for joining us today, everyone. We're wishing you a very safe and healthy start to the holiday season, and this concludes our webinar. Take care.